All right, good morning. So let's talk about the unstable pelvis, or pelvic stability is really what this talk is about. I don't have any disclosures except I'll just tell you that there's no real data in this talk. This is simply a summary of how I actually think about these problems. There's some data behind it. There's some mentoring and teaching that came my direction that's behind it, and there's now some experience behind it. This is my 10th year in practice, but you're not going to see a lot of data. But there'll be plenty of data later in the course, and you can take a nap when that's presented. Okay, so we're going to talk briefly about what stability is, and then the factors that I think about to help me decide if a pelvis is stable or not, and then just touch very briefly on how I use classifications to think about this as well. So kind of similar to what David just said about the cervical spine, we sort of functionally define stability in the pelvis, right? So if someone comes in with a pelvis fracture and you're trying to decide if it's stable or not, what you're really asking yourself is this pelvis going to still look like a pelvis 6 to 12 weeks from now if this person gets up and tries to function? Or are they going to come back looking like this with a deformity, a lack of union, and probably some pain that's functionally limiting? So we're trying to avoid this when we ask ourselves, is this pelvis stable or not? And so it's an important question because it is dichotomous in terms of where I go from there. If you have a stable pelvis, then we're done. Your weight bearing is tolerated, and I'll see you once at 6 weeks to console you, and that's pretty much it. If I decide you have an unstable pelvis, then you get something like this. You get an operation. So it's a vague, important question with a dichotomous outcome. All right, so here's the meat of the talk, which is how to figure this out. So we know we want to figure out if a pelvis is stable because it determines if we operate or not. It determines if the pelvis is going to be deformed and painful or not if we don't do anything. Unfortunately, there's not a good agreed upon way to figure this question out. And I am positive there's a bunch of people kind of over here that are going to disagree with some of the things I say. And that's okay, because as I said at the beginning, these are my thoughts, not theirs. So this is what I use to try to figure out if I think someone's pelvis is stable. If you guys want to take a minute and jot this down, history, physical exam, and imaging, this is what I use. So nothing unusual, just the normal stuff. Okay, so the first question is the history. What's the HPI? So basically, I'm asking myself, did this person have a low energy injury or a high energy injury? Are they young or are they old, right? Because this HPI is just not the same as this HPI. These people may have very similar looking x-rays and CT scans, but the way they got this trauma is not the same, and the soft tissue envelope that you can't see on all your imaging is going to be differently preserved in this person than in the person in the car accident. So I do actually think this is worth considering. Okay, don't just jump straight to your x-rays. Also, another thing that I use is the social history. What I'm really asking myself when I talk to a patient and learn about who they are as a person, I'm asking myself, what are the chances this person's going to come back and see me? Okay? And this may push you one way or the other. For me, it usually makes me slightly more aggressive with how I'm going to treat them if I don't think they're going to follow up. But this is why I do this. So here are the last 4 years of trauma patients that I took care of. All right. The first solid blue line is if you just average Joe trauma. All right. And the second line there is if you have a hobby of doing methamphetamine or fentanyl or heroin. Okay. And then right in the middle of the graph is how likely you are to come to my clinic at 3 months. 3 months, which I think we would all agree is maybe barely long enough to decide if your pelvis is going to heal. So if you're average Joe trauma, you show up about 2/3 of the time. If you have a substance use disorder, then you show up about 1/3 of the time. So I'm more aggressive with the bottom line because I just don't know if these people are ever going to come back. And in fact, most of the time, they do not. Okay, so that's the history. And then what about the physical exam? I think there's a limited amount of information you can get from the physical exam, but obviously you can look for ecchymosis, and then you can touch the pelvis and see if it feels unstable. And you can feel if it's not only unstable, but if it generates a lot of pain. It's sort of soft data, but it's still worth doing. It's free, takes a few seconds, so I think this is worth doing. And then now let's talk about imaging, which is what we all tend to jump to right away. Before we even see the patient, we look at the images that someone else got. And so there's kind of two categories of imaging that you can use. There's static imaging and there's dynamic imaging. So let's talk about both those. Okay, so static imaging, X-rays, CT scans, there's really three kind of broad categories of things that I'm going to ask myself. The first one is, how displaced is this thing initially, assuming there's not a binder or something else that's going to get in the way of me interpreting that image. And I think we would all agree this is probably predictive of how unstable this pelvis is. And similarly, this different pattern of injury, but this is also probably somewhat predictive of how unstable this pelvis is going to be when they try to get up and mobilize, as opposed to the pelvis that still basically looks like a pelvis, but just has a couple of cracks in it. So initial displacement. The other thing I ask myself, particularly in the back of the pelvic ring, is the completeness of the bony injury. All right, so this is a sacral fracture, okay, but if you just say that someone has a sacral fracture, that's, for me, generally not enough information to make a conclusion. This is a trivial sacral fracture, okay? This is an incomplete sacral fracture that, to me, is going to be very likely to be stable when this person gets up and walks around. Okay, and this is the other end of the spectrum. This is someone who has a LC3 variant, and they have a complete, very displaced sacral fracture on the left and SI joint widening that was caused by external rotation from the left hemipelvis on the right. This is, to me, very likely an unstable injury that's going to require some intervention. So the completeness of the bone injury in the back of the pelvis that's by far best evaluated on a CT scan is very useful to me. And then I just count rami fractures. So there's some evidence to show that this is helpful. So this is a guy with 2 rami fractures, and this is someone with 4. I think the front of the ring doesn't contribute nearly as much as the back of the ring to pelvic stability, but it's at least a marker of how bad the injury was. I think you would all agree it probably takes more energy on average to break 4 rami than break 2. So those are the gross things I look at on X-rays and CT scans for my static imaging. Okay, then there's dynamic imaging, and this was described a number of years ago now. So if you haven't made your mind up based off the history, physical exam, and static imaging, this is another thing you can do to try to decide if a pelvis is stable. So you take someone to the OR, you put them asleep, and you push on their pelvis. And this is an example of a pelvis that I think we would all agree went from I'm not sure to really pretty unstable looking. And then here's one that's kind of in between, and I would say this is a more common scenario, someone with a lateral compression type injury, and you push on their pelvis, and as you go from the left-hand side to the right-hand side, you can see the pelvis gets squished in a couple of centimeters, and so it looks less stable than it did before you started pushing. I actually find I use this tool significantly less often now than I did at the beginning of my practice. After pushing on a lot of pelvises, I realized I didn't really know how to interpret this very well. Maybe this nice 86-year-old just needs me not pushing on her pelvis for the next 6 weeks while she's trying to heal. As far as I know, no one has ever shown that this is predictive of how people do later. It's predictive of you getting a screw in the operating room, for sure. It's not that predictive of, or we don't know if it's predictive, I guess, is what I should say, of what your pelvis is going to look like 6 to 12 weeks from now. And you're already asleep in the operating at this point, so it's very hard not to put a screw in once you've got an image that looks like this. Okay, and then let's touch base on some classifications before I wrap it up. So here's the tile classification. And in theory, this is a great classification for this problem because essentially it's trying to put people in 3 buckets, and it's the buckets that we want to know about. Are they stable? That's bucket A. Are they rotationally unstable? That's bucket B. And then bucket C is, are they vertically and rotationally unstable? So that's great. That's the question I'm trying to get to with this talk. I find, however, that I have to put patients in this bucket myself using the stuff that I just talked about. So while ultimately it's asking the question that I want to know, I actually don't find it useful to help me make the decision. It's just useful language, because then I can tell Dr. Matayahu, okay, well, there's a tile C, and he already knows that I think that needs surgery. This classification, I think, is a little bit more useful for me to think about whether or not a pelvis is stable. And I won't go through the whole thing, but just to show you how I use it. So we'll start with the APCs, these open book pelvis. So I think we would all agree, as you go from mild to moderate to severe, the likelihood of this pelvis being unstable is going up. It's just a progression. So that's fairly straightforward. For the lateral compression injuries, unfortunately, the classification system doesn't work like that. So ones don't become twos that then always become threes if enough energy is applied. These are just different anatomic injuries. So APCs are a progression, lateral compression injuries are not. So an LC1 is in the sacrum, an LC2 is in the ilium, and an LC3 is either a 1 or a 2 that then hits the other side and that side externally rotates. So it's quite different from an APC injury, but you can still use this, or I still use this to think about pelvic stability. So there's a bunch of subcategories for each of these. I don't want to make this too long, but so let's start with the LC1s. So again, that means you get hit from the side, and the injury is in the sacrum. That's all the one is telling you, it's in the sacrum. So I sort of mentioned this before, but you know, the injury in the back can range from being incomplete and probably totally stable to complete but not displaced to complete and very displaced. And again, that progression to me is going from likely stable to likely very unstable. Twos are just a different animal. Again, these are injuries that anatomically are in the ilium somewhere or the SI joint. And there's two twos for me, so there's sort of this classic crescent that's confined to the ilium. To me, that complete bony injury is very likely to be unstable. And then there's this other type of LC2 that involves the SI joint. And I think these are a little bit more likely to be stable because there's some soft tissue that's probably still intact on the anterior aspect of that sacroiliac joint. And then finally, if you put someone in the bucket of LC3, that's just an inherently unstable pelvis. Typically, they're very displaced on the side that got hit, and the other side is externally rotated. So these, for me, are always unstable, and similarly with vertical shears. Those are just always unstable injuries. Okay, so that's my thinking on stability. Again, it's a question of whether or not a pelvis is still going to look like a pelvis 6 to 12 weeks from now if you let it get up and walk. There is no good way to figure this out. You're going to have to use your brain your whole career, and you're going to have to use basic tools to help you answer these questions and make a judgment. And then the classification systems we went through very briefly. I personally think the Young and Burgess packages some of this nicely together to help me think about pelvic stability. All right, thanks very much.